Good evening, everyone, and welcome to tonight's webinar sponsored by OCULUS and how to use axial length for your myopic patients. Thank you, everyone, for attending tonight. And in a moment, I'm going to introduce our wonderful panel. My name is Dr. Bill Tullo, Medical Director at OCULUS, and I'm going to host tonight's event. And I want to remind everyone there's a chat function. You can put your questions in the chat function. We're going to leave some time in the end to answer all your questions. Let's take it away. I'm going to skip through my disclosure since it's a very short slide. And I want to introduce our first panel member, Dr. David Kading, CEO and Clinical Director of Specialty Eye Care, graduate of South Dakota State University and PU College of Optometry, residency done in cornea and contact lens. He's a fellow of the Academy of Optometry, fellow of the Contact Lens Society of America, and he specializes in custom complex contact lenses, and the owner of Optometric Insights. David's disclosure slide is slightly different than mine. And just a quick bio of David. I'm sure everyone on this webcast knows David, but he's been recognized as one of the top optometry influencers of all time, as one of the top 250 innovators. He's listed as one of the top 10 best practices in eye care. His 3 practices in Seattle focuses on dry eye specialty contacts and myopia management. He co-owns Optometric Insights, which is changing the way students and doctors perceive practice. He performs research as part of his postgraduate residency, and he hosts in Seattle. He lectures internationally. He's written thousands of papers. His podcasts, the OL Show and the Myopia podcast, are released weekly and downloaded by practitioners nationwide. Most of all, Dr. Kading loves spending time with his 3 daughters and his optometrist wife, Dr. Christy Kading. Welcome, David. Our second panelist, Dr. Andy Morgenstern. Dr. Andy Morgenstern is a graduate of Nova Southeastern University College of Optometry. Boy, Andy, you've got a lot of distinguished awards, so I'm going to just let the people read through those.
Quote a friend. How about that? Pass.
There you go. President of the International Keratoconus Academy, which is a great resource for keratoconus education. Past president of the Optometric Cornea Contact Lens and Refractive Society, or OCCRS, and director of the AOA Evidence-Based Clinical Practice Guidelines, which we're going to actually bring up here in a moment. One of his disclosures is he was the original idea behind the Myopia Master for Oculus. He came to us years ago with the idea of combining these essential functions that we'll talk about later in the Myopia Master. He's also developed a secondary software called the Morgenstern Myopia Report for educating your parents. And you can see he doesn't receive compensation for these things, but he has an honorarium for tonight's presentation. He's also one of the co-authors of the Clinical Report on Myopia Management from the American Optometric Association, and again, a very influential paper on myopia management. Our third panelist tonight, Dr. Jason Jedlica, Chief of Cornea and Contact Lens Service at Indiana University College of Optometry. Jason did his residency and fellowship training and at PCO, or now known as SALIS, fellowship also in anterior segment disease at the great Minnesota Eye Consultants in Minnesota. He was Chief of Contact Lens Service at University of Minnesota Department of Ophthalmology from 2000 to 2010. He served as clinical adjunct faculty for PCO and ICO Colleges of Optometry, past president of the Scleral Lens Education Society, incoming chair of the membership committee of the Academy of Optometry. He's also a fellow for the Academy of Optometry and the Scleral Lens Education Society and the Contact Lens Society of America. And as you all know, he's lectured internationally and written many articles, books, chapters on contact lenses and anterior segment disease. Welcome, Jason. So thank all 3 of you for coming tonight to this webcast. Looking forward to some spirited conversation about myopia management. And let's start out with like the most basic concept is, what's the big deal about myopia? Why now? And why it's been around for thousands of years. Why does myopia matter? Let's start off with David. David, why don't you lead us on this conversation?
Yeah, well, myopia really does matter. And I think historically we've just thought about myopia being this nuisance, as this refractive error that makes people see blurry. Well, the reality is many diseases go along unnoticed, but we happen to have a blurry vision that accompanies the severity of this disease. And it's not the blurriness that's the problem. It's the eyeball growing longer and longer and bigger and stretching more and more, that we really realize. Our friend Mark Bullimore did some incredible work and really has kind of showed us about how each diopter matters in the increased risk of maculopathy, glaucoma, visual impairment, and so much with each diopter, meaning that you have a substantial risk of increasing in your level of these diseases when you go up by 1 diopter from a 0 to a 1 or 1 to a 2, a 2 to a 3. Each of those diopters, it increases your overall risk of visual impairment, your overall risk of developing a disease substantially. We've historically only thought about this being a problem for high myopes. Well, we realize now that me as a -152 myope, I have a 2 times greater risk of developing glaucoma than an emmetrope, right? I mean, if you said to one person, we can voluntarily give you a 2 times greater risk of a visual impairment or a cancer or heart disease, nobody would be like, oh, that's not a problem. But we do that all the time in eye care, thinking that a -2 myope is a great thing because when they're presbyopic, they're going to see up close just fine. So we've tended to poo-poo this disease by and large historically, and now we're just realizing that we can't do that any longer. We need to stop this disease, and we need to first of all call it a disease, and it's happening worldwide. We know the risks by 2050 are astronomical. Everybody that's on this panel knows this, and everybody that's listening just knows of how myopia is increasing. We've seen it, really increase with the other pandemic going on, with how many more children are becoming myopic far faster. And so we really can reduce this progression and slow this down. And that's why we need to be thinking about this in a new way compared to how us old farts used to think about it when we were in optometry school.
Yeah, it is tough for some of our older practitioners like myself to change the mindset that we've been accustomed to for so many years, especially starting out with absolutely no tools to stop myopia. Now that we have more and more different options and good effectiveness of these options, it really has changed my way of thinking, which for 30 plus years was different than it is today. Andy or Jason, anything you want to add?
Jason, I have something to say, but I'll let Jason go first. How about that?
Well, I was just going to say, and David brought this up already, but this is the transition in thinking to myopia management being a refractive versus a medical eye care. This is medical eye care. This is not a refractive thing, and we need to realize that. So that's all I wanted to say.
Yeah, obviously we're talking about like the title of the presentation said, axial length. David brought up some really good points, obviously, but axial length, just like he said, myopia matters, axial length matters as well. What I mean by that is that, David was talking about the research that our buddy Mark Bullimore did on how, rates of different conditions increase with a diopter. It's not really just a linear relationship like that. And that's why I think axial length is so important to be measuring. For example, in my mind, I think of, increasing myopia kind of like intraocular pressure, where someone who has a pressure of 18 their optic nerve may be safe, but someone else who has a pressure of 18 may not be safe. And so you're looking for relative change. When you put patients on medications, you're looking for relative pressure drop. I think it's the same thing with myopia. Somebody may be safe with an axial length of 24 millimeters. Some people may not be safe with an axial, of 24 millimeters, but it's the relative change from visit to visit. So when your patients are coming into your office for myopia management, I try to identify those patients that have the axial length problem, and documenting it is incredibly important for this condition. There are going to be some myopes that are myopic, like me. I've been a -250 my whole life, and I don't have increased risk of disease. However, that's not always the case for everybody, but there are going to be some that are okay. I just happen to get lucky. But for your patients that you're watching over time, especially when they're coming in at a very young age, looking at that axial length is very important, because you need to identify risk factor and risk association with change. And so that's all I wanted to say.
So let's talk a little bit about what is myopia management. And you all alluded to the fact that we're looking at more than just the number of diopters a patient measures on each visit. And there are lots of different methodologies and treatment options available. Jason, why don't you talk a little bit about some of the options we have currently, and then maybe after that, David, you can chime in about some future options.
Sure. I mean, so the lifestyle stuff, the outdoor time, good lighting, all that good stuff, and that applies to everybody. So no matter how else you're managing myopia, we need to talk to our patients about that aspect of things for sure. As far as the appropriate manner of managing the myopia for each individual child, it's going to depend upon, again, their age, their refractive status, etc., their need for vision correction. I'm going to be obviously not as excited to fit a patient who's a -1/4 in ortho-K as I'm going to be to put them on atropine. So tailoring the management to the appropriate needs of the patient, where they stand again with age and refractive status. And then again, I think there's that window of time, and we've all seen it. There's that age between 6 and 12, which is really the hot time for progression for a lot of these kids. And during that time, we've really got to look at ourselves and say, hey, combo therapy for this should be the norm anymore. Whether it's ortho-K or soft multifocals or multifocal spectacles, or some type of myopia managing spectacles in combination with atropine. And again, what concentration depends upon you as a practitioner. But I think that's got to become more and more the norm, that a combo approach to this, especially again in that window of time when the kids are most vulnerable to the big jumps in the refractive error, is something that should become increasingly the norm. So we have a lot of ways to manage it. And again, whether you prefer ortho-K, soft multifocals, or some future version of spectacles, I think it's going to depend upon the age, the refractive error, the life situation of that individual child.
David,
I'll jump in with a couple things here. I don't mean to be self-promotional, but I kind of do. I've learned an incredible amount about myopia from my podcast, so I may be referring back to it, but we had an incredible podcast where we just talked about how we tend to be future myopic progressing thinking, as far as like, what are the things that we do to help slow things down in the future, but we're not thinking about what are the things that people are doing currently that are driving towards the myopia. And Jason, you led into that, and that's the lifestyle changes, right? I mean, if somebody is on diabetic medications, but yet they're still eating at McDonald's every day, you're kind of fighting against yourself. And so what are we doing lifestyle wise to really slow this down? And I had a, beyond what we can talk about, Justin, with this, I had a great podcast where we just laid that out. I think it was with Afe Vanderwart, and really spoke to that. So we can't oversimplify this lifestyle modification to be what it really is. As far as what's coming out in the future, there's some incredible things that are coming out in the future. Spectacle lenses are obviously a big one. We don't have them in the United States, but we're looking into that. I had a guest on my podcast that's utilizing artificial intelligence to be able to track where the eyes are in the pair of glasses, so that it can specifically target how vision is going to be targeted towards the back of the eye, and already has a prototype for that. It's going to be a while before that's on the market, but that's kind of some cool stuff. Obviously, we've got some incredible different mechanisms with the spectacle lenses that are coming available. There are a couple pharmaceutical approaches that are out there outside of just atropine. Those seem like they're a little bit further away, and we just haven't necessarily targeted all the receptors that we need to for myopia, but they're getting closer, and so that's exciting. And then I think that we're just making huge advancements in our knowledge with orthokeratology, and ortho-K is just a simple thing to do comparatively to how we thought about it 15 years ago. Right? Ortho-K really is something that needs to be mainstream. There was a study that was called the SMART study looking at one specific type of lens where they were, 85% successful with the first set of lenses that were empirically fit based upon Ks and HVID and the refraction for the patient. So when we can get to a point where we're more successful with a pair of ortho-K lenses than we probably are with our soft multifocals for our presbyopes, why are we making it so difficult and saying it can't be done? The beautiful thing is that we've got great solutions, and we're just going to be continuing to get better and better.
Just to add to that, Dave is spot on. Just to add to what he said.
Thank you, Andy. I'll put that down in my diary tonight.
You check that. I gotcha. We also have better technology. Not, and obviously this is this presentation is sponsored by Oculus. Their technology is phenomenal. I'm not paid to say this at all. I use it every single day of my life, and there are some devices from Oculus that, quite frankly, I couldn't even go to work with without using. But if you look at the kind of armamentarium of diagnostic devices that we have these days, orthokeratology is not what it used to be. We're so much more accurate with lens design. We have so many people at all these contact lens companies that can assist us in designing a lens that's right for a patient, and even troubleshooting with patients. And so it's a lot more straightforward than it used to be in the old days. And I agree with David that we really should be taking advantage of it more, because we can be so much more accurate for these patients.
Andy, I did my first ortho-K patient 34 years ago, and the idea of one and done didn't even exist. I mean, if you got done with 3 or 4 lenses, you were successful, and the lenses would never center. And this was even before we had reverse geometry lenses. It was a nightmare trying to do orthokeratology. And for people who did it back then, it's hard to imagine how much better it's gotten. I mean, now I exceed 90% one and done, and it's just amazing how well it does work now.
It is. And not to toot his horn, but Jason designed that Zen lens, which it's a phenomenal device, and they've got it nailed down now, where it is very straightforward in fitting and designing for a patient, and like I said, the support that you can get. And I'm not trying to promote him, but I do want to give him his due, because he really put together a really great product that, combined with the technology, can really do some good things.
Andy, the Zen lens isn't for myopia management.
Oh, I know. It's still a great contact lens, and it's not. Somebody call my page.
All right, Jason, hand the $20 to Andy so we can move.
Yeah, right.
My Venmo name is.
So Andy, I want to ask you a little bit about, one of the more difficult things that it took me to learn is that when you're dealing with children in orthokeratology or atropine or any other myopia management, conversations with parents are essential and key to success. So why don't you tell me a little bit about what you do, what you say, how you handle parents, and any tricks you can teach us?
Sure. The trick number one is you got to get a little lucky, right? So if you have 2 myopic parents that are walking in your door with a myopic child, they understand. They understand what life is like as a myope, especially as a high myope. And I think addressing their problems over the course of their life and something that we can slow down, because they understand, you take any -8 and they understand how much better life is as a -4 than it is as a -8. And so that conversation, if you're lucky enough, and I say that, not lucky to be that myopic, but for the purposes of the discussion, if you're lucky enough to have myopic parents, address it through what they've experienced so far, because they understand that language of myopia throughout their life. The other thing is put it in terms of what Dave said before, that myopia, myopia has been around forever, but we didn't have technology like we do now. Yes, they knew that there were myopes in the 1400s, but they didn't have the ability to track rates of different conditions and diseases and so on and so forth, and associate them. So educating the parents is incredibly important. Genetics, right? And that's the big one here, is that explaining to parents that, it's very obvious if you have, there's a lot of myopic families out there, that this can be a really big issue that could be worse than what they started before it. I think the most important thing these days is to also put it in terms of solutions. And what I mean with solution, Bill, you and I come from the world of refractive surgery. We know that LASIK, when we started with LASIK and PRK, it was something that was, it was like the Ferrari of eye care. Now it's almost expected that if somebody's myopic when they're an adult, they'll just go and get some sort of refractive surgery and get rid of their glasses. Well, we all know that the higher prescription that they have walking in the door, the higher rate of enhancement there is. And the higher rates of enhancements are really where the complications happen. So having them understand that this is a lifestyle change that can help them later on in life, it can help them with future refractive surgery, that's obviously important as well. And then getting back to behavior modification, to tell them, the parents, that they can actually intervene in their kid's lifestyle and help to make a difference. Get the kid outside, get them off the computers all the time, get that exposure to that natural light. All those things are really important. And then obviously talking about how the treatment's going to happen. I think setting expectations is really important. Before the call started, one of the things that we were talking about was not using big absolute terms like we're going to cure this or we're going to absolutely stop this. We're going to slow it down, hopefully. And so could you stop it? Sure, you could stop it, but I would not set your goal as that for the parent. I think setting reasonable expectations that you can achieve is really important.
Jason, you want to add anything to that?
I'd just say that I was giving a talk a few weeks ago to a group of non-myopia managers, and one of the things they mentioned was this is the hardest part for them in a lot of ways of getting started is, how do I have that talk? What do I say to parents? How do I begin this process? They're not so much intimidated by the idea of prescribing or of talking about behavioral modification. It's just, where do I begin and how do I begin? And I say you just have to dive in at some point, and you can't just keep putting it off saying, I don't know where to begin. You've got to have this discussion, and starting today is better than waiting.
I'll ask you this question because I think it's important for the audience. What do you guys do when you have the resistant parent, right? I talked about the one who's the myope before, but hey, we've got this myopia management program for your kid who's progressing, and one or both of the parents are like, I am not buying it. I don't know what you think you're talking about, but you're not doing this on my kid. How do you guys address that?
Yeah, I do the same thing I do with any other disease. Is I say that's okay. My job is to educate you. That's what you pay me for. You don't pay me for anything else. Is education. So let's check back in 3 months and see where we're at, and we'll see where things are at. And it's up to them whether they come back or not. But the reality is, just like with a glaucoma patient or something else, you need to show them that the progression is happening, and then as they're willing, send them resources that can help them understand the risk factors and so forth of progression.
Yeah, and document that you had the discussion in your records so that it's clear that you explained this to them and it was their decision.
Yeah.
The nice part, my experience has been, is that when you're dealing with parents regarding their children, I get a lot less pushback when it comes to their treatment versus treating the parent themselves. They'll pass on an option for themselves, but it's less likely they're going to pass on an option for their child to keep them from getting worse. So I think it's a frank, no pressure conversation with the reality of what's going on and what the risks are, and most parents will choose what's best for their kids. It does make it a little bit easier. So let's talk about the goals of treatment, because I think we mentioned right now, we talked about not telling parents we're going to stop this disease, because we can't always reliably do that. But David, let me ask you the question: when you set goals with parents, what kind of words do you use? What do you say?
Yeah, well, Andy already alluded to this a little bit, and that is that you have to put it into terms that is important to them, right? That -8 myopic parent who couldn't have LASIK surgery would pay double or triple what the cost of LASIK is if they could have it and not be -8. So if it's something along those lines, and say, even things along the lines of this, this is the sort of thing that we can do, and later on maybe you would be able to have LASIK, and they're like, oh, that would be fantastic. But really pointing out to them that our objective with this is to slow the progression of the eyeball elongation or the eyeball growth. And, just from a terminology standpoint, I don't like to talk about the eyeball getting longer. I like to talk about the eyeball getting bigger. It tends to resonate a little bit more with that there's stretching that is going on, and as that stretching is happening, it's putting a stress on the tissue, which isn't going to be an issue in the next 10 or 20 years, but is going to be an issue as time goes on, and then those risks are there. Really, I think the goals that we really kind of strategize with the family about goes down into two different categories. One is the risks of the disease, and I think that kind of goes more into our doctor goals, and we talk to the parent about that, like, this is the thing that we really need to be focusing on from the disease standpoint and slowing it down. But as Andy alluded to, the other side of it is the lifestyle concern is, there's a very different lifestyle of a -2 versus a -8 or a -5 in the functional ability. And we want your child to be able to go in the swimming pool without their glasses and be able to see okay. We want your child to be able to function, on a Friday night to go run and get a gallon of milk, and maybe if they didn't have their glasses, they'd be able to walk there and be okay, right? When the apocalypse happens and all glasses and contact lenses go away, we want your child to survive. And those are the sort of things that we kind of point to, is the lifestyle as well as the disease concern. But parents don't hear the disease concern too much. They hear more about the lifestyle. So it's really important for us to bring both of those things into the conversation.
And Jason, when as far as you the doctor, what are your goals as far as a treatment? Let's just pick any treatment, atropine or any treatment. What are your goals in your mind? What do you want to see 3 months down the line, 12 months down the line? What are you looking for clinically?
Well, that's interesting, because I think that especially when you first start myopia management, you've got to have a long-term view of things. You're not gonna start managing myopia and feel like after 6 months after you start, like, wow, look at all the improvement I made in these lives. You haven't seen it yet. It takes a few years of doing this before you really start to understand the change you're making in some of these kids. I saw a girl today who's 13 years old now. We started managing her myopia when she was 6 years old, and she was a -3 at the time. And through the last few years and measuring her and whatnot, I was able to explain to the mother that, in 7 years now, she's only progressed maybe 1 diopter. And so that was exciting times. But, so for me personally, I'm managing for every bit of reduction of progression as I can, realizing it's not going to happen. We're not going to stop it completely. I'm looking at, again, the axial length, as Dave said, more than the myopia prescription itself. I'm focused more on that, and again, just having a long-term view that some kids are going to progress, and some kids are going to progress, more than you like, but you don't realize what they would have progressed were you not intervening. We've all seen a kid go from -150 to 3 in a year. So if you have a kid who progresses half diopter, don't panic. Just be more focused with your therapy, up the treatment if you can, and just, fight the fight.
Yeah, and I certainly less panicked on a 6-year-old increasing a half diopter under treatment than maybe a 13 or 14-year-old, which I would expect less and more effective, slower growth of the eye. So let's switch gears a little bit, David. Let's talk about your myopia management examination. When you're examining a child, and maybe it's your first exam or maybe it's a repeat exam, what are the aspects that you're looking at? Obviously refraction, but what else are you looking at?
Yeah, well, if this child tends to be myopic, then I want to know the history of their myopia, if at all possible, and so we'll refer back to prior records if the child is coming into the office or into our own records and look what has happened from a progression standpoint. But beyond that, before we leave the phoropter, we'd like to know what their accommodative status is and their binocular status is. My wife is a binocular vision specialist, and so if we don't talk about that, then I don't get to sleep in the bed at night. But such an important component of that is if they do have an accommodative system that is completely out of whack, Our first thing actually is to send them over to vision therapy and get their accommodative status and their binocular status back in alignment, because I may be completely off on the amount of myopia that they truly have, which brings us to the second part that we like to do, is we like to do some sort of a psychoplegic refraction on a child. We don't necessarily have to do it every single year, but at some point we like to have some psychoplegic information to know where that child really is. And if there is a difference, a substantial difference between their psychoplegic versus their dry refraction or RET, then again, we start suspecting some accommodative problems and refer them into a binocular vision clinic. To that end, I don't do binocular vision in my practice. I just fortunately have it in my practice. If I didn't have it in my practice, those kids would be going elsewhere to get an accommodative binocular workup before they would do myopia management. So I just want to stress, I think that's important. Obviously, if we're thinking we're going to be moving into a myopia management system, then I want to get a really good topography so that I can see what might be a good option for them. Am I going to be moving in the direction of orthokeratology, or should we steer away from that into another direction? And then we also do axial length with our kids in the office. In fact, we've made axial length part of every pediatric exam and are doing more and more of it on adults as well. And to that end, today I did a podcast with a practitioner up in Canada, and she has axial length part of every single pediatric exam that she does. And what was really interesting is she found an emmetrope who has who had an axial length of 26, and that's a really big eye. The average emmetropic adult is a 24. And so this kid is an emmetrope, and they just have a huge eye, and they used to be hyperopic. And so they're like transitioning towards emmetropia, and she just hit them now. And so axial length is a really important component, even if the child is an emmetrope, and it really fits in. And so that has become more of our workup with our patients as well.
Anything you want to add, gentlemen, to that?
Of course, slit lamp and retina. We look at that too. I don't want to say that we don't do that. That's part of every exam.
Yeah, I think Dave hit something on the head in that the question is, what does a pediatric eye exam look like in 2022? We learned what a pediatric eye. I graduated in '99. I learned, my pediatric eye exams between 1995 and 1999. Technology was completely different. Methods were completely different. Research was completely different. Have I changed my methods in my exam room to fit with the research that's changed and the equipment that's come along? And, that's something that I always kind of try to remind my students, how important, what's more important on a 7-year-old healthy kid? Is it more important to make sure you get a perfect IOP measurement, or is it more important to get an axial length measurement? Well, we know we have to check the IOP in most states by law for a comprehensive eye exam, but I would say that the axial length measurement is a more high yield test, and you're going to get more data and more information on what's going on with your patient's eye than you will from that IOP measurement. So I think, that's really important. To me, a pediatric eye exam, one of my favorite tests on planet Earth in all eye exams is a cycloplegic autorefraction. I think that it's probably one of the most data plentiful tests that you can do in a pediatric eye exam. And that with axial length, I would love to see all pediatric practitioners doing, cycloplegic autorefractions and axial length measurement on all their pediatric patients, because I think it's going to give them a lot of information on what's going on with the eye, in addition to everything else, obviously, that we're required to do. So I think you should be headstrong about thinking about what is a high quality, high yield exam test during your exam for these kids.
So I think we all agree that axial length is an important factor. I've heard it multiple times from each of you. I think obviously knowing the amount of myopia is important for making the diagnosis, but for monitoring progression, I think we all probably agree that there's no better measurement than axial length. And in particular, when you're dealing with ortho-K patients where you're altering the cornea, it's really the only way to measure if they're progressing or not that's reliable. So what's the best way to measure axial length? David, why don't you talk a little bit about the different methods and what you choose to do?
Yeah, well, for clarity, in the creation of this presentation, this slide was created by Andy. It had nothing to do with me. I just want to point that out.
And I thought it'd be more fun to make you talk
the
about
pictures that we're not allowed.
Yeah, there was a picture that was on here that was removed. We'll put that on there. Yeah, well, you know, we obviously have the ability to do, you know, axial length in an incredible way with this non-contact method, which is utilized by the Myopia Master, the you know, the IOL Master, and so forth. And those devices are pretty fast and pretty easy to do and very reliable. The alternative is the contact method, where you actually are in contact with the eye, and you know that's an okay method to do axial length. It's better than nothing, but the problem with it is kids don't like it, and I want kids who really want to come to my clinic, and you know, I can give them all the candy and all the toys and everything, but if I have to numb their eye and touch their eye when they're in the office, you know, we question a little bit of some variability with some of those tests, and we looked at getting one right before the Myopia Master was available, and that was an inexpensive method to go into axial length. And I thought, well, hey, let's just do this. But then I started realizing, what's it going to take to actually get this done? Is it going to be something that I get excited about having my patients come in every 3 months to do? Or every 6 months on you know, on a long end. So what's the best way to measure axial length? I would say the way that kids are going to be cool with it being done, the way that it's going to be easy and fast for you to do. And the thing that really, I think, stands apart, and again, we're not, Bill, you didn't set this up to be a Myopia Master promotional thing, but every patient who comes into my office that does myopia management, whether I see the patient on that day or I'm just measuring data, they always get an autorefractor, right? They always do. And so the fact that the axial length is combined in the Myopia Master with a device that I'm going to be doing anyway, and Andy cycloplegics every one of his patients the moment they walk in the door, and so it works really well for him as well on the autorefracture. But that's the reason I like the non-contact, is because my patients don't mind having it done. It's quick and it's reliable.
I'm going to try to catch us up a little bit on time. And obviously, there are a lot of different biometers out there, most of which were designed to do adult measurements for cataracts. So they weren't really designed with children in mind. The Myopia Master, as you see here, if you're not familiar with it, it's a device that looks like an autorefractor. It's a very small footprint and very child-friendly. It's not intimidating at all. Very easy to obtain the measurements. Very sleek and fast. It gives you your refraction, your axial length, and your keratometry all in one sitting without having to move the patient. It only takes a few seconds to obtain the measurements. The device, again, is very sleek and has a lot of great software. We'll talk a little bit about some of the software in a moment. But really, the beauty of it is the speed and accuracy and the repeatability of the measurements in kids as young as 6 years old. So it gives you all three things that you need essentially, but it does so much more than that. It gives you a data analysis. It takes your data and it plots it on a graph. It shows change over time. It has a questionnaire, so you can ask risk factors to your patients and enter the risk factors into the questionnaire that can give overall risk of the patients. It's educational. I mean, using this with your patients and your parents in the exam lane is really essential and important. All your treatment recommendations, whatever you choose to do, can be customized in the software, so that when you give a printout to the patient, this report is essential. Because I don't know about you guys, but I know that one thing is, if I only have one parent during the initial encounter with the patient, the other parent is going to be calling me and asking me lots of questions, and giving these very detailed, easy to understand reports to the parent so they can go home and not be interrogated by the other parent about what just happened. It makes my life a lot easier easier, and it makes the other parent's life a lot easier, not needing to explain things. And also over time, watching progression over time with normative data. Our instrument does have normative data for both Caucasian and Asian eyes using the Brian Holden Vision Institute's graphs. So it really does a lot more than just measure the eye. Again, it gives us the data analysis, the questionnaires, the patient education, treatment options, take-home report, and the ability to follow these patients up. And here's just an example of the axial length growth charts, where over time we can show where the patients could be predicted to be without treatment, and then where they are currently with treatment when treatment began. And here's just the incredibly easy to understand, easy to read myopia reports that are generated by the device. So really great patient education. Let me ask a question to Jason about recording axial length, and how do you monitor it, and how do you physically record it over time, and do you use delta measurements, or how do you do that, and how do you use those numbers?
Yeah, so in our medical record software, we just have a place to record axial length as part of the refractive exam, and we're just recording the true measurements from each visit, as opposed to changes in from one visit to another.
So there's no linear relationship exactly between diopters and axial length. It really does vary a lot. David, do you want to comment a little bit about that relationship between diopters of treatment of change and axial length in millimeters?
Yeah, well, so it there is a light correlation, but even from the example that I shared before, is you can have a gigantic eye that is at risk with a low refractive error. And to that end, I'll also mention you could have a patient, who's got a -3 who has a small eye, and for that sake, we have refractive correction either on the K values or in the lens that's changing that. And so, when we know that axial length, it really tells us more about the overall eye health, because this is a health exam, as Jason pointed out, not just the refractive error. In many of the studies, we have seen that many times the refraction somewhat follows the axial length. So that's been the reason why we still feel like you can initiate myopia management on a patient who is progressing, even if you don't have an axial length device. And if you haven't bought one, I would still encourage you to do myopia management. It just changes the game entirely once you do get axial length and you feel more comfortable that you're managing these patients a little more effectively. But by no means, we haven't had great devices until just recently. By no means should you hold back on doing myopia management if you don't have a device.
Andy, do you have an opinion on that matter?
Yeah, I do. So number one is that if you look at any treatment that we use for myopia management, whether it be atropine, orthokeratology, contact lens, soft multifocal lenses, even the new lenslets that are coming out in the spectacle lenses, the goal of the treatment is to slow axial length growth of the eye, right? So if you're using a treatment that's primary purpose is to make you lose weight, you want to get everybody on a scale as you have them on that medication to see if the medication's working. If you're using a medication or a device to slow axial length growth of the eye, you want to get a measurement of axial length to see if your treatment method is working. For kids that are progressing with myopia, any myopia management is better than no myopia management, absolutely. However, if you're going to do this based on all of the research that's available right now that looks at this stuff and understanding how the treatment methodologies are working, axial length is it's the primary measurement. It's the primary data point for these patients, and it's something that has to be done, in my opinion.
Okay, well, you guys have certainly met in the middle here a little bit more. Your opinions have become more similar over time, which I think.
I would say, here's the thing, is that I don't want to say to not do it. If there's a kid out there that's suffering, just like with any other condition, obviously you want to get them as good treatment as you can, but you can't be accurate unless you're measuring the axial length, because that's the problem. The problem isn't the myopia. The myopia is the secondary effect of the axial length increase of the eye. So if you're only using Ks and refraction, you're missing the primary endpoint, which is the axial length. It has to be done. I'm just saying that, you know, if you
I think what I'm hearing is we've got a consensus on we are now actually agreeing upon a strategy for your kids that axial length is the best way to go. But if you don't have one and can't afford one yet, still doing myopia management is still in the best interest of your patients.
Absolutely.
It is, and I think the place where we're really realizing is we now have devices that are not just standalone devices that you have to go and spend a ton of money and build this device and put it in. You know, you're going to get a new autorefractor. You're going to get a new device that does keratometry at some point. So now's the time to start be thinking, hey, if I'm doing myopia management, I got to be doing axial length. Why wait 5 years? We can now bring it in a little bit sooner with devices. I would not have held the same opinion with these expensive standalone devices, because from a primary care optometry standpoint, we have limitations in our practice as to what we can buy and how much we can buy and what it all does. But now we're starting to see devices that are coming on the market that do more than one thing. And so now I'm becoming more of an advocate for it. But that didn't keep me from doing myopia management. I just wasn't doing it as effectively as Andy has eloquently pointed out.
All right, so let's talk a little bit about establishing baseline measurements. Obviously, with atropine or soft multifocals, your baseline measurements are your first measurements. But with orthokeratology, things are a little bit different. Andy, you want to comment on baseline measurements?
Yeah, so I think the most important thing, as historically proven by refractive surgery, is to make sure that the eye is in a neutral or, you know, essentially a virgin state, in that if the patient does wear any sort of contact lenses, they need to be out of them for a significant amount of time. So you can get a remember, your baseline is the most important data point that you're going to have over the course of the lifetime of this patient. You want that cornea to be as neutral as possible. And we know through all the LASIK and PRK that we've done over the years that soft contact lenses manipulate a cornea, rigid gas permeable lenses manipulate a cornea, scleral contact lenses manipulate a cornea. And what I say by that, it changes the shape. If it changes the shape and flattens the cornea or even steepens the cornea, that could affect the overall measurement of axial length, because Bill, you know, based on the science and the way these devices are working, I'm assuming that the axial length measurement, the non-contact axial length measurement of this device, measures by a light source, and it pings off the front surface, pings off the back surface, and measures the difference in between. If you have a curvature change due to contact lens warpage of the cornea, that's going to affect, because you got to remember, we're measuring down to the 100th of a millimeter with these eyes. We're not measuring to the millimeter, we're not measuring to the 10th of a millimeter, we're measuring to the 100th of a millimeter. And a contact lens, if it changes shape 2, 3, 4 diopters, can easily change the axial length of the eye measurement.
We know from the OCT epithelial thickness studies of ortho-K patients that there is definitely significant movement and thinning of the central cornea where the axial length is taken from the vertex normal. So that's the area that's thinned the most, and typically with ortho-K. So again, using your baseline measurements before you start ortho-K would be an error. You really need to, I usually wait and I take measurements on my first few visits, and usually by 2 to 4 weeks after ortho-K is where I can feel comfortable that's my baseline. But I'll keep taking measurements for the first few weeks just to make sure that I've established a new baseline.
Completely agree.
All right, so David, why don't you talk a little bit about how often you do axial length and how often do you look at that number clinically?
Yeah, well, you know, axial length is one of those things, kind of like IOP, is the more you measure it, the more comfortable you are with that data point. The data point is a stagnant data point, but when we're checking to see whether our treatments are effective, you know, one data point is just a dot, but as soon as you get a secondary data point, you can see a line. And as you get more and more and more of those data points, that line becomes more significant and substantial for what you're trying to do. And this all relates back to the growth curves that we are focusing on. Is what is a growth curve for somebody who is 6 years old for their eye elongation? Our objective here is not to stop the eyeball from growing. Our objective is to slow the progression as much as possible. we know that growth is going to occur over time. And so if we can say that over the last 3 years, this growth has happened at this rate, and then we intervene and we can see a change. And you had an image from the Myopia Master a couple slides back that pointed to that and showed that, you know, it did in fact slow the progression. So every single time the patient comes in, every single time you do an autorefractor, you just click on the axial length measurement, and within just a couple of seconds, you get that data. As Jason put, you just put it into the record, and then you can have that data point. Fortunately, with the Myopia Master, because it goes into the data set, you can just pull that up for the patient, and it maps it out for you so you can see where it's at. It becomes a really slick way of doing it. If you don't have a Myopia Master, then just take that data and graph it for your patients so that they know what the change is over time, to help them understand whether the treatment is working, whether you want to continue doing that treatment, to help you understand whether you need to adjust or modify, or whether your treatment is working as you would anticipate. Every time the patient comes in is the answer to the question. Oh,
Excellent.
how often? Every 3 months and every 6 months in office.
Yeah, I've got to jump in on this before we go any further. Just you talked about establishing a baseline and how often you measure. The reality is your baseline that you take before you start any management at all is your long-term baseline. But once I put a patient on any type of therapy, I'm reestablishing a new baseline on that therapy. That is now my baseline until I stop that therapy. And then I can revert back to my naked eye baseline. Because like you said, if I put a patient on atropine, or if I put a patient in ortho-K and I reshape the cornea, I may change the axial length in the immediate short term because of my therapy. And if I then use my original baseline as my baseline in the management process, it's not necessarily accurate. So again, I like to reestablish a baseline. If I put a patient on atropine, I want their axial length a week later, because that is now the axial length I will use as my baseline, as long as that patient is on that therapy. Again, until I can't stop the patient's therapy and wash them out for a month to go back to my original baseline. It's just not, you're not going to do that. You're not going to stop therapy on a patient to get a new baseline. So I would suggest that your baseline is going to be a baseline for the long term, but anytime you start a new therapy, you've got to reestablish a baseline that it will work as your baseline as long as you continue on that therapy.
So we're running low on time, so I want to ask each of you a couple of more questions, and then we'll take some questions from the audience. Jason, I'm going to ask you this question. When you're talking to a parent and they say to you, well, how long will my kid need to do this? Does he need to do it forever? Is this a finite treatment? How do we know when we stop it, or do we never stop it?
Sure. I think that, again, I think there's a window of time when the greatest amount of change occurs. You can see that in all the normative data. And so there's a time to be extremely aggressive with managing myopia. There's a time that comes probably mid to late teens where change occurs less, but we all have seen kids continue to change beyond that. I think it's really important just to make sure that parents are aware that while there are times of life when change occurs more rapidly, it can occur anytime in life. And especially if your child is in a situation where they're doing a lot of close work, they're doing a lot of indoor work, they're at higher risk for change, that time of change may never happen. And so a lot of times we target a future time as end of high school, college years, somewhere there. But again, we always make sure to tell the parents, look, I've seen kids change a lot even through their college years. So if you want to be on the safe side, there's no reason you cannot continue the optical modalities of myopia management well into adulthood.
All right, well, I'm looking at the questions we're getting from the audience. We're getting some very good questions. So I'm going to throw this one out to anyone who wants to answer this question. And here's a very basic question. What is the normal axial length increase for a 10-year-old in a typical 12-month or 1-year period?
For a 10-year-old?
For a 10-year-old.
You know, so are you saying the axial length absent of refractive increase?
Yeah, well, so what's the normal amount? And so then you can derive what is not normal.
Right. So I think you have to work backwards to be, I think you have to remember that a 0.3 millimeter increase in axial length typically correlates to a 1 diopter change in overall refraction, assuming that the Ks are still normal. So I would typically, over a 12-month period, hope that, assuming that the Ks are the same and assuming that the refraction is not changing, I would hope that my axial length measurement is changing a tenth of a diopter, a tenth of a millimeter or less at that point. And you're looking at for the old additive effect. You have to remember, though, there is always going to be an increase in the eye is not a static organ, it's a dynamic organ. Our pressure in our eye changes every second, every minute as the diurnal variations change. Our keratometry readings change as our eye grows. I think everybody always forget that the skull has to grow with time because we're getting bigger. And as the skull grows, the globe inside of the orbit has to grow with the skull. Think of it, someone who has an enucleation, they don't just leave the socket empty. They have to put a implant in the eye to hold, so the orbit doesn't collapse. So the globe has to increase in size with the skull, with the orbit, as the patient is growing as they get older. So you are going to see an increase in size. That's okay. It's the increase in size relative to the refraction and relative to the Ks. And I think that's why this device is so important, because you're going to watch those things change simultaneously at the same time. But I would say a tenth of a millimeter or less of change is a-okay.
So, Bill, I'll jump in real quick, and I know we're wanting to be somewhat quick on this, but there was a study that Tidman done and looked at 9-year-old European myopes, and what they found is that they experienced a 0.34 millimeters of axial elongation in a year, and that ranged between 0.17 and 0.53. So this is all across all different levels of refractive correction, most of them being myopes. And then if you're looking at Asian children, Rosma did a study and found that for 7 to 9-year-old kids, and these were Asians, they experienced 0.3 millimeters of growth, and that slowed to about 0.2 millimeters of growth by the time they got to be about 12 or 13. So as they get past 10, 11, and get into 12 and 13, we kind of think 0.3 is somewhat normal, but that could be more for certain myopes when they're in the younger years, and then 0.2 when they get into 12 or 13. But if you average it out over all of the years, they say 0.1 is the number that we really want to be referencing. If you can keep everybody progressing at 0.1 millimeters, to Andy's point, you'd be in really good shape with myopia management. But you may be wanting to do more slowing down of the progression when the kids are younger, to Jason's point that he said earlier. And there's a great publication that kind of outlines all of that. And if anybody wants that, they can email me and I'd be happy to send it to them. Or Bill, I don't know if we could put that in the chat section.
We can. So I'm going to close it with a question to Jason. Okay, go ahead, Jason.
No, I was just going to say, again, it all goes back to where you're starting from, too. If I've got a kid who's a 26 millimeter eye already, I care more about that 0.1 of change than if they're 23. So, that's where the axial length comes in, is how aggressive do I have to be to minimize the health risks to this eye? And without knowing that actual number, you don't really know how aggressive you should be.
I think Andy's analogy with glaucoma makes sense here, because if you're dealing with a 0.9 cup, you're going to tolerate way less issues than you would with a 0.2 cup with some pressure changes. So I think that's a good way to think about it, Jason. I want to close this, and I'll start with you, Jason, with this question, because we get to answer this question every time we do a webinar on myopia management, and it goes back to atropine. And so are you a start at 0.1% and build up, or are you a start at 0.05% and build down? So how do you do this, Jason?
Yeah, I'm right in the middle. So, go back a few years ago, I was 0.01 on everybody, because that's kind of where we were at. And as the LAMP study came out and we changed that, I'm at pretty much 0.025 on everybody. Depends sometimes if they're real dark eyes will go, stronger. If I'm doing other therapy and it's combo, I might go less, but 0.25 is the sweet spot and move up or down depending.
David, you want to comment?
Yeah, I absolutely do. I'm a big go as hard as you can, as much as you can, and deal with the consequences of the side effects, because the side effects are really not health related, they're just vision related, and that's a very easy solution to fix. And so I'd much rather gain the benefit of the higher concentration and have the couple of patients that I've had struggle with it and come back. And I usually will educate the blue-eyed individuals that that's possible for them and that it's an easy fix for us to just go to a lower concentration if we need to. But I usually start with the best and the most effective treatment that I can, and I'm always willing to back off later if I need to.
And Dave, you may have convinced me of that tonight too, by the way.
I'm sorry?
You may have convinced me of that too.
Yeah, I still have so many patients who react to the 0.05% that I'm closer to Jason than I am to David today, but ask me again in a week.
Highest tolerated, well, your highest concentration that's well tolerated is, I think, probably the best way to put it. Every patient's going to be different. You want to medicate to the patient and medicate to the condition, not just to grab, I think, just one flavor across the board, assume everybody's going to like it.
Well, in order to find out the maximum concentration that is tolerated, you have to go to a higher concentration and start there, and then you come back.
I think the key with David's methodology is really good parent education, so that when you do have the patient who has the blurry closed vision or the dilated pupils, that it's not a surprise. I think the problems are always when you start with the 0.05%, they do have a side effect, and they weren't aware that that could have been an issue. So
you're focusing way too much on the vision of the child. We're trying to slow down the progression of their myopia, and if we can dilate their pupil with orthokeratology, we're probably benefiting them for their myopic effect.
Let's just be honest here. How many times have you seen a kid in your practice come in with 10 millimeter pupils and never complain of glare and halo? But if you had that same patient that was 50 years old, it's the worst thing on planet Earth.
What's the worst thing that happens to an ortho-K patient? They get old enough to drive a car.
Yeah,
right.
Yeah, then they start complaining of the same glare they had for the last 10 years, and now they're complaining about it because now it matters.
That's true, but you know, Ortho-K is so great for adults too. I'm an Ortho-K wearer, and I love it, right? And I drive a car.
Yeah, and plus the other thing about Ortho-K that's so great is how much of a champion are these kids for your practice when they don't have to wear glasses and contact lenses all day long. I mean, they tell every one of their friends, their parents tell all of their parents. It's the biggest practice builder that I've seen in the last 30 years.
Well, to be honest with you, for that question that you asked before about, you know, what if you have a patient, what if you have a parent that asks the question of how long are they going to have to wear this for? Well, if you put them in Ortho-K, it don't matter, because you got to correct their nearsightedness anyway, and now they're actually doing it absent of a spectacle correction. So why it doesn't even matter at that point. You're actually getting the contact lens out of their eye, you're getting the glasses off of their face, and you're correcting them, and you're doing their myopia management at the same time.
Yeah, the line that I use on my parents is I say, ideally, we'd like your kid to wear this through college if possible, but it can be stopped at any time.
Yeah.
Well, I want to thank you guys. You made this a really fun conversation tonight, and I hope the audience got some good pearls out of this. If anybody has any questions, I put all our email addresses up there. Feel free to reach out to us. We're happy to answer any questions you have, and thank you very much, and have a great night, everybody.
Great seeing you. Have a good one.
Thanks, everybody.